Assalamu alaikum everyone. I'm Dr. Safdar Sial. We shall be discussing a very important topic today, that is renal or kidney transplantation. History of renal transplantation. The first successful renal transplant was a living donor transplant performed between identical twins. Both the donor and the recipient were identical twins. They were genetically similar. It was done in 1954 in Boston by Professor Joseph Murray. He was basically a plastic surgeon. Was the transplantation when the donor and the recipient were not genetically identical was done later on, but that failed because no effective immunosuppressive therapy was available. This is Professor Murray Joseph Murray. Indication of kidney transplantation. Previously, it used to be end-stage renal disease when the GFR drops below 5 ml per minute, but now the latest recommendation are that it should be done even in patients with CKD5 when the GFR below 15 ml per minute, but not necessarily below 5 ml per minute. For these patients, there are two treatment strategies. One is dialysis, either hemodialysis or peritoneal dialysis, or renal transplantation. Etiology of end-stage renal disease or CKD with chronic kidney disease is glomerulonephritis, hypertensive nephropathy, diabetic nephropathy, renal vascular diseases, polycystic kidney disease, pyelonephritis, stone disease, and obstructive uropathy. These diseases lead to end-stage renal disease or chronic kidney disease. So, advantages of transplantation over dialysis is a good quality of life. It's cost-effective. Transplantation is cost-effective. So, in patients with ESRD, there are less morbidity and mortality when these patients are rendered to kidney transplantation as compared to if they are put on dialysis. So, recipient selection criteria, which are the patients who can get the kidney transplantation? Age between 2 and 74 years. Patient should be infection free. Patient should be cancer free. No evidence of any cancer in the body. There are very low risk of disease recurrence in patients with diabetes and hypertension. So these are ideal patients, diabetic or hypertensive patients, because there are very low risk of disease recurrence. And similarly, very low risk of disease progression after transplantation in patients with ICV or HB positive or HIV or any malignancy. So in these, if these patients are kidney transplanted, there are low risk that the hepatitis would deteriorate or the HIV infection of the patient would deteriorate. So patient recipient selection, there are high risk diseases, focused segmental glomerulosclerosis or primary oxalosis or hemolytic uremic syndrome. These are high risk patients because there are high chances of recurrence of disease in the transplanted kidney. So, and there is moderate risk of HIV, hepatitis B, virus, amyloidosis or cystinosis and SSA. So, in these patients, when there are moderate risk, you can go ahead with kidney transplantation, but where there is a high risk, kidney transplant should not be done. So, the contraindication to kidney transplantation: active infection inside the body. If the patient is immunodeficiency HIV with HIV, or patient has cancer anywhere in the body, and there are less chances that the patient would survive. So in these patients, kidney should not be transplanted. Donor selection, age of the donor should be between the age of 18 and 58 years of age. Patient should be clinically and physically fit. So what are the types of donor? Living donors and cadaveric donors. Living donors may be related or it may not be, or non-related, or it may not be related. Cadaveric donors may be brain dead or heart beating donors. I mean, the heart is working but the brain is dead. Evaluation, there are certain routine tests which should be done, blood tests which we do in every patient of surgery. Hepatitis B, C, CMV virus and HIV, this is the viral load of these patients should be checked. X-ray test should be done, ECG, echocardiography should be done, ultrasound of abdomen, IVU, renal angiography to look for the vascular anatomy of the donor kidney should be done. DTUA scan should be done of the recipient to look for any residual renal function. And these HLA typing and lymphocyte cross match, these are the specific tests which should be done, on which we decide whether the kidney matches or there is a mismatch. So lymphocyte cross match should be negative. Pre-operative donor preparation, patient should be, donor should be fully hydrated, give diuretics, pre-operative antibiotic cover should be done. Patient should be NPO since midnight. Similarly, pre-operative recipient preparation, dialysis should be done 24 to 48 hours before operation. No blood transfusion for the last 4 weeks, because if you give the blood transfusion, it will lead to development of antibodies and there are chances that the transplanted kidney may be rejected. Urine culture and sensitivity should be done, iodine body wash at night, good antibiotics, and patient should be nothing per mouth from midnight. So transplant surgery, first I'll discuss the donor side of surgery, from which side the kidney should be taken. Better functioning kidney of donor is saved. It should be with the donor instead of removing it. If both kidneys are equally good working, then left kidney is taken for transplantation, because the left kidney has got a longer renal vein than the right renal vein. Donor nephrectomy, it can be done either by open method or by laparoscopy. When done by the open method, incision is made either through the 12th rib or supracostal approach. Kidney is removed along with the Girota's fascia, taking renal vein, renal artery and ureter as long as possible. This is by the open method. This is the renal vein, this is renal artery, and these are the ureter. And this is how laparoscopic nephrectomy is done. There are usually 4 ports are applied. The kidney is dissected, the vessels are cut, and ureter is cut, and the kidney is actually is the laparoscopic assisted nephrectomy. Then phenol-steel incision is made here, like this one shown here, and then the kidney is removed from here. Transplant surgery, recipient operation, site of transplantation. Mostly right kidney, transplanted kidney is put in the right iliac fossa. But if the right iliac fossa is not available, left kidney can be transplanted in the left iliac fossa, or where the native kidneys are lying, or in the upper abdomen using aorta or superior mesenteric artery for anastomosis. This is the native kidneys, and this is the transplanted kidney in the right iliac fossa. Here the renal vein is anastomosed with external with the common iliac vein or with the external iliac vein, and similarly the renal artery is anastomoted with the external iliac artery. But most of the people now, they have been doing, the vein is anastomosed with external iliac vein, and the artery, renal artery, is anastomosed with internal iliac artery instead of external iliac artery. Transplant surgery technique: lower abdominal calcaneal incision is made. This is called Gibson incision. Transplantation bed is prepared in iliac fossa, mostly on the right side. Iliac vessels are exposed and mobilized. This is the Gibson incision. It may be can be extended like this one, upward. Kidney preparation. After donor nephrectomy, kidney is taken in ice slush made up of Ringer lactate solution. Kidney is flushed and prepared for transplantation. This is a saline slush where the kidney is placed and frozen, and the renal artery and vein, these are flushed with these saline flush. So the blood vessels, blood cells inside the blood vessels are removed. Renal transplantation procedure. Kidney packed in ice slush is transplanted in the iliac fossa. Right renal vein is anastomosed with the external iliac, and the renal artery with the internal iliac. The ureter is anastomosed with the bladder by modified Greger leach technique. Diuretics and steroids given per-operative as well as post-operatively. This is how the kidney is placed, the same slide, and this is when the artery is anastomosed to the internal iliac and the vein to the common iliac vein. Post-operative care. Patient is kept in transplant ICU with complete emergency kit and separate post-operative caring team. Urine output is maintained at least 1 ml per kg per minute. CVP line is maintained at 11 centimeter of water. Fluids are given. Normal saline and 5% dextrose water are used in a burette with KCl replacement according to body requirement. Post-operative care: antibiotics, diuretics, oxygen inhalation, and there are certain tests are done. These routine tests are done on daily basis. Immunosuppression is the induction therapy. The immunosuppression drugs are given right during starting the procedure, and then the maintenance therapy. This is when the patient post-operatively they are given immunosuppression therapy for few months, then for few years, and then few drugs for the rest of life. And this is the treatment of acute rejection. Complications: blood clots, leaking from or blockage of the ureter, infection, failure or rejection of the donated kidney, and infection or cancer that can be transmitted with the donated kidney, and sometimes patient may die due to heart attack or stroke. Transplant rejection: hyperacute rejection that it occurs immediately, per-operatively, immediately on the table. This is due to preformed antibodies present inside the blood, will lead to hyperacute rejection. The preformed antibodies are usually formed by pregnancy or prior blood transfusions or previous transplantation. Then is hyperacute rejection, and then is acute rejection. In first 6 months, if rejection occurs in the first 6 months due to T cell or B cell mediated immunity. Symptoms is fever, pain at the transplanted site, decreased urine output. Signs: tenderness at the site of transplantation. Ultrasound of transplanted kidney shows graft swelling, decreased sinus fat, prominent renal pyramids, increased vascular resistive index more than 70%, and pelvic infundibular thickening. These are the findings on color Doppler. Number 3 type of rejection is chronic rejection, occurs after first 6 months. Most common cause of graft failure is this chronic rejection. Antibody play an important role in chronic rejection. It is characterized by myelointimal proliferation in graft arteries leading to ischemia and fibrosis. It's a process of gradual decrease in renal function over times of years, and it cannot be prevented. It is also called chronic allograft nephropathy. Technical complications, vascular complications, urological complications, and some other complications. In vascular complications, which usually occur preoperatively, renal artery thrombosis, renal vein thrombosis, renal artery, this is preoperative, and then the renal artery may stenose over years. Renal artery leakage from the renal artery or renal artery disruption may occur sometime. Urological complications, ureteric leakage, ureteric disruption, and sometimes ureteric obstruction. And sometimes there are other complications like hematoma formation, urinoma, and lymphocyte. Non-technical complications like acute renal failure, cyclosporin therapy, cyclosporin in toxicity, certain infections, and development of malignancy postoperatively. Causes of acute urine output postoperatively, usually acute rejection, acute renal failure, or cyclosporin therapy. Graft survival is 97% at 1 year, 85% at 5 years. Total survival time approximately 10 to 15 years after kidney transplantation. May work up to 20 years with good immunosuppression therapy. Thank you very much. God bless all of you.